Hey everyone, this is Kellie Simpson, Vice President for Finance and Accounting for Ballad Health, and today we're going to talk about some information that you're going to need to know as future healthcare administrators. The first thing we're going to go over today is an overview of the current state of healthcare. So just a little bit of perspective, the cost of healthcare in the United States is approximately $10,000 per person, and our median household is 2.6 people. Median income before taxes is $55,000. So the share of the average healthcare cost for each household is $26,000, which leaves approximately $29,000 a year for 2.6 people to live off of. So just to break that down, $3.2 trillion cost of healthcare, and by category, you can see by far most of that is spent on hospital care with 32% of the total, and then physician and clinical services with 20%, prescription drugs 10%. So if we look at the annual health cost in relation to the GDP, you can see that overall it tracks a little bit at the same increase with just a little bit more each year than GDP. But when we look at that from a cumulative standpoint, what that really means is that health expense is growing exponentially faster than our GDP growth. So this slide represents the limits of cost shifting and that we are approaching those limits. So if you look at reimbursement to cost in healthcare settings from 2000 to 2009, you can see that Medicare and Medicaid has went from approximately 95 and 99% down to approximately 90%. So what that means is that for every dollar that we spend on healthcare costs in a hospital setting, 90% is reimbursed by Medicare and Medicaid. So we lose approximately 10 cents for each dollar of spend. While on the private payer side, that has increased from 116 to about 134%, which means that for each dollar that's spent in a healthcare setting, that hospital would get reimbursed approximately $1.34. So what that has mean is that those commercial payers has really helped absorb the cost for Medicare and Medicaid in those government populations. So they have always made up for and helped keep the hospitals covered. There's a lot of pressures on commercial pricing lately. One, increased regulatory scrutiny of premium increases, also limited opportunity to further leverage scale with consolidation, and then also greater employer pressure for more insurance options. So we're really at the limit of being able to cover this from a commercial standpoint with the limited reimbursement for government. So this is another slide that really represents this in another view, and then that the Medicare and Medicaid volume growth is unable to finance capacity expansions, replacement of equipment, and that's really been covered by the commercial payers. But as we look at moving to the future, we are moving more and more to a single payer. So you look at the volume by payer class from 2011 to the projections for the country in 2021, 35% commercial down to 27%. So an 8% reduction in commercial payers is projected over a 10-year period, with Medicaid staying pretty stable, just 2% decrease, self-pay going from 5% to 0.3%, and then a vast majority of patients being covered through Medicare. So approximately 52% of the U.S. population qualifying and receiving Medicare coverage. So with that ratio from 2011, 1.7 public to commercial beneficiaries up to 2.7 projected for 2021. So if you look back on the previous slide of the reimbursement to the average cost, you can see that we're really at a point where this isn't going to last. We're not going to be able to cover that from a cost standpoint to reimbursement, with approximately 70 to 75% of population in the United States being covered by government payers that the healthcare industry really loses money on. So looking at population trends, and this is specific to Northeast Tennessee, Southwest Virginia, estimated population changes is showing really a lot what the last slide showed, but even more in this area, that our population continues to increase at a higher level. So assuming the CDC mortality rates by age group, people 65 and older will grow 3.6% over a 5-year period. And on top of that, that 75 and older is growing even faster at 6.2% over this 5-year time frame. So any improvements that are made to mortality rates will just increase the population size, and the impact of the elderly population trends on utilization is expected to be offset by population health efforts. What that really means is that our population is getting older, in particular in this area, which means that there will be more Medicare, more Medicaid, and then that will need to be covered by the younger population. So if we look at case mix projections, it's another good slide with the current 5-year and 10-year projections looking at the surgical versus medical. So for each surgical procedure, you get paid quite a bit more than you do medical. So you can see over a 10-year projection period, really looking at that shifting about 3%. So this puts more pressures on the healthcare industry. And then the outpatient is looking to stay pretty stable with a little bit more imaging, and the surgical share going down a couple percent. So the long-term cost growth continues. So if we look at cost in the healthcare setting, this is a graph that represents the expenses per adjusted admission. So in 1989, it cost approximately $4,588 to serve an inpatient. In 2009, that was up to $10,045. So that's increased quite significantly over a 20-year period. There are 3 main cost drivers. One is market pressures that are continuing to push up units and cost of labor. So everyone wants to get paid more every year. There are also nursing and physician shortages, which drives up the cost of labor in healthcare setting. Overhead expenses, there's a significant amount of money that is spent towards IT, both from a mandatory regulatory standpoint, being able to share data across different sets and continuums of care. And then in general, the United States has a more aging, sicker population that is more complex and costs more to care for. So just to take a look at Medicare spending, so 32% of Medicare's annual budget goes to care for chronically ill patients in the last 2 years of life. So that is approximately $74 billion that's spent on the last year of life. And of that $74 billion, $40 billion is spent on the last 6 months of life. That's $222 million a day. So just to recap what we went through in this section to frame up where we're really at with healthcare as a nation. We're having continuous pressures on the cost that are increasing and driving expenses up in healthcare settings, while at the same time, more population is becoming older. They're moving towards Medicare and Medicaid payers. There's more pressure on commercial payers, and then that shift is moving over to payers that pay less. So we're getting reimbursed less, and it's costing more to perform that work. So next we're going to go through exchange plan, high deductible plans, and patient pay. So this is really important to understand as we see a shift in patients who have exchange plans, and then a lot of employers are moving to high deductible health plans. This has a significant impact on healthcare companies. So just to look through the economy on the rise. So there's a lot of news lately that the economy is increasing, that the household wealth is increasing, but if you don't really take a deeper dive to this, it's a little bit misleading. So really looking at an income growth inequality. So while overall the household wealth is increasing, between different individuals, it's quite drastic. So this slide really shows the top 10% of the economy versus the bottom 90% of earners. So if you look from 1949 to 2012, almost all of the income is going to the top 10% wealthiest in the country. So looking through sort of the 50, 60 years, there was more income that was going to the bottom 90% of the population than the top 10%. And then starting in 82, moving forward, that has drastically shifted where almost all of the increase in wealth is going to the top 10% wealthiest already in the country. So while the economy is up, pay is not. Wages have stayed flat for the average hourly wage, and there's a decrease in unemployment, but that's seasonal, and then also it's at that same rate. This just sort of sums up a middle-income American family makes substantially less money in inflation-adjusted terms than it did 15 years ago. So when we look at that from an overall economic standpoint, looks like we're rebounding from the recession. There's no real evidence from an individual standpoint for middle, low-income Americans that's actually making an impact. It's actually the opposite, that they're making less money than they did. So looking at this from a population standpoint really shows the same thing. So the median net worth of individuals 18 to 34 years old has decreased from 89 to 2003. So you can look in the early 90s, it was approximately 18,000, and in 2013 that went down to 10,400. So, and rising cost of health insurance. So the annual cost of employer family health coverage and that portion that's paid by workers. You can really see that with the high deductible health plans as well. But if you look at 2000 compared to 2015, the average cost is a little over $5,000-$6,000, with most of that being paid for by the employer. And then in 2015, you can really see around $16,000, $17,000, with around $5,000 being paid by the employee. So that's less inflation adjusted income, and then a higher burden or use of that income goes towards the insurance premiums. So this is just from an actuarial ratio, the percent of an average patient's expected cost of care that will be paid by health insurance. That went from 80% down to the statutory actuarial for the ACA mandated plan was only 60%. So what that means is that the average patient out-of-pocket obligation is doubled. And so looking at this slide, it's the percent uninsured from 2013, 14, and 15 by county, by state. So you can see that from 13 to 15, there was a significantly higher portion of the population who have insurance coverage, less uninsured, but a lot of those are going through the exchange plans and the high deductible health plans. So this is an example of what that payment means, both from a hospital standpoint and then also a patient standpoint. So if we look at traditional versus a high deductible health plan, let's say the patient comes in, they have an MR of the spine. So in the first circumstance with traditional insurance, the gross charge is $3,252. The the insurance contractual is $2,016, which means that the hospital expected payment is $1,236, which is really the same across all of these. So the hospital is contracted with the insurance company to get reimbursed $1,236,00. So under a traditional insurance plan, there's typically some portion of copay, 10%, 20%, 15%, that patient would be expected to pay. So in this circumstance, the patient would pay $309 out of pocket, and the insurance would cover $927. So under the second example for the high deductible health plan, the individual has a $3,000 high deductible health plan, and they have met $1,400 of that $3,000. So if you go down to the bottom, what that means is that the insurance will not cover the procedure since the patient has not met their high deductible. So the patient is responsible for paying the full $1,236 out of pocket. And then in the third circumstance, that's a high deductible health plan, the patient has already met their $3,000 deductible for the year, and then there's a lower copay. So a 10% copay versus a 20%. The patient would pay $124. The insurance would pay $1,112. Of course, this patient has already paid $3,000, at minimum $3,000 that we know of for other services throughout the year. So that does put a significantly higher burden on the patient when they go to seek health care. And from a hospital standpoint, what this means is, if you go back to this example, that patient that had a high deductible health plan, hadn't met it, paid $1,236. They may not be able to afford to pay all of that for this MRI. So if we look to 2012 to 2013, if you have gross patient revenue of $449, the contractual adjustments, and then as you can see, the charity increases and the contra revenue and bad debt significantly increased, while the net patient service revenue decreased. So the reason for that is because that a lot of those patient copays or out of pockets for the high deductible health plan has gone to bad debt or charity. So that second patient that had the $1,236 out of pocket may not be able to pay for that. So that net revenue per admission or per outpatient visit decreases, the total deductions increase, but the bad debt increases. So as you can see from a trend perspective, that bad debt greatly increases and the uninsured discount charity increases. So some of those payments that were essentially a little bit more stable or guaranteed to be paid by the insurance company is moving over to that out-of-pocket, which is no longer a guarantee since a lot of those individuals can't afford to pay for that. They either qualify for charity or those claims go to bad debt and the hospital does not get reimbursed for a lot of that. So to move on and now discuss the future state of healthcare. So as we talked about a little bit earlier, we do have an aging population. We expect to continue to see this increase. So the baby boomers have started retiring in 2008. They're going to continue to retire. New retirees each year will increase 60% over the next 20 years. So we can expect to see more and more people in retirement age. And what that means is once you retire, or around the time that you retire, you probably will become eligible for Medicare. A physician shortage, so we're projecting a physician shortage. There's also projections on nursing shortages as well, where the supply is not able to meet the demand, and projections for 2025 is demand of 916,000 physicians with a supply of 785,000. So what that means is that those physicians will be more in demand, but will also be harder to retain and attract those individuals to certain areas. which will drive up labor expense. We're also in the middle of a payment restructure. So under a lot of the old payment models for healthcare settings was fee for service, pay for volume, which essentially means that you do an MRI 10 times, you get paid 10 times. So you get paid for the work. And we're currently shifting that reimbursement over to value payment, continuity of care. So really sort of right-sizing the revenue structure based off of quality and outcomes and payment for providing better care. Right now, we're sort of in that straddle point where we're still fee-for-service, but we're moving towards that value payment, which means that the revenues really dropped, volumes are decreasing, minimal rewards for quality. So under the future payment system, we can expect to see more alternative payment models. So CMS, the Center for Medicare and Medicaid Services, started to change their fee-for-service to alternative payment models. So you can see in 2016, 30% of payment structures were alternative payment models. They're expected to increase that to approximately 50% in 2018, with over 90% of their payment in some form linked to quality metrics and performance. So you can see readmission. This is one of the areas that Medicare is really focused on from a payment standpoint. You do currently get penalized for too many, what they would consider possible avoided readmissions. Once they implemented this into the payment structure, 43 of 49 states saw decreases of more than 5% readmission rates, and rates fell by more than 10% in 11 states. That's about 565,000 readmissions for Medicare beneficiaries. So really seeing a lot of improvement in that. As we continue to see more improvement where the revenue is linked to performance and quality, then I think, of course, more of those reimbursement models will shift to that. So just to look at the patient care path, it's really important as we look at some of the value-based models that are coming into play. But if you look at this from an episode point, there's a lot of clinical care or care pathway reimbursements models that are coming out that really look at payment along the continuum of care. So if you look at that patient care path, go to triage, ED, urgent care, some type of setting that initially the patient comes in with a condition. They may get moved to an inpatient status, get treated, and then there are potential post-acute care sites, whether that be rehab or home health, skilled nursing facility, some type of rehabilitation out after the inpatient stay, and then they moved home. So if you look at the payment rate increases across some of these settings, you can see that it's really been marginal, but there is some variation here within the different settings. So we had a 0.24% change in physician payments, approximately 1.7% on hospital outpatient, a little under 1% for hospital inpatient, 2% for ambulatory surgery centers, 2.2% for psychiatric services, then around 1.5% to 2% increases in post-acute care settings, and then actually a decrease in reimbursement in the home health settings. Just another slide to represent the penalties and quality programs. So these are Medicare-related programs that are currently in place. There's the readmission reduction program, which they continue to add more procedures. So CABG, it's an inpatient heart procedure, was added to that readmission reduction programs list. And then HAC, Hospital Acquired Conditions Program, added 2 measures, and they've changed the scoring methodology for that. VBP, Value-Based Program, measures now are equally weighted with outcome and safety measures. So we're now up to a 2% penalty from 1.75 for this value-based purchasing program, which means that Medicare will penalize you up to 2% of your inpatient reimbursement if you aren't meeting that metric. And what that is 2% on every patient, not just the patients that come in that maybe your quality isn't the best for those particular patients, but it's for all of your future payments with Medicare. And so CMS is also moving to do a site-neutral payment structure for post-acute services. So MedPAC reports details based on patient characteristics, not setting. As they move through 16 through 21, they're defining and collecting quality and cost measures and developing risk adjustment tools. And 2022, they're set to report to Congress. And then in 2023, MedPAC will submit to Congress the details of this design to do the payment restructure for post-acute services, which will really be more and more based on those quality, cost measures, and value to the consumer. Comprehensive APCs. So this is an area that's not specifically defined as a quality or pay for performance, but it's really another way that from a reimbursement standpoint puts pressure on healthcare as an industry to move towards that. So a C-APC is a mini DRG. So you get a single payment for the vast majority of billed items and services on the outpatient claim. They're based on the cost of most billed services on that claim and is packaged into the primary service. So there's 25 C-APCs that were first introduced by Medicare in calendar year 2015, and 10 additional C-APCs across 14 different clinical families were added in 2016, including observation. Most add-on procedure codes are packaged. Some are used if there's a complexity adjustment. And then for 2017, 25 new C-APCs were finalized with more than 1,800 procedures typically in the surgical setting changed to these payment rates. What that means is that there's a single package for a significant amount of procedures that are done on an outpatient basis. So if a particular hospital maybe overutilized certain services or ancillary services really in imaging, drugs and pharmaceuticals, supplies, lab tests, they do not get paid extra for that anymore. So it really puts a lot of pressure on the healthcare setting to look at the procedures, the tests, the scans that they're performing to determine if that's really necessary and drive down utilization of services that really will help reduce costs, because the payment structure is set up where you get paid the same regardless of the amount of ancillaries that are performed with that case. So looking over a 4-year period, you can really see in gray the shift. So in 2017, of these 2,736 services that were packaged, in 2014, almost all of them were paid separately. And we continue to see more and more of these each year with Medicare. So from a case volume standpoint, 83 in 2016, approximately 83% received separate payment, with 17% being packaged. And then in 2017, an additional 2% of outpatient procedures were packaged. So this is going a little bit more each year to looking at that package payment. So again, just then what we're sort of under now, straddling the first two, pay for volume, no quality is measured, to value-based payment, quality is measured, and looking at process improvements to the future, looking more at care coordination, quality outcomes for an episode, a disease, and whole system improvement, and really looking at payment structures that follow that patient through that clinical care pathway. So how do we as a nation and as a healthcare industry succeed at value-based contracts? Is that we need to move away from silos to converging support for the patient's need throughout the settings that they need for their condition. Value-based contracts, so just looking at our specific area, value-based contracts in local PCP practices, whether that be mandatory or optional, very saturated in our area, more than you would probably think, in PCPs for value-based metrics. So approximately 30 to almost 45% of our area have some type of VBC participation in PCP practices. So those primary care physicians are actively engaged and working to get their patients to the appropriate setting, making sure that they do not utilize the ED inappropriately when it may be more appropriate for them to utilize an urgent care setting or come into the physician office. So really trying to help right size that care for the need. And additional influences on reimbursement. So it's not the payers, which has always been an influence on reimbursement, but really looking at those quality and performance metrics that are coming into a lot of the contracts. And then physician practices. So again, these PCPs that are actively trying to work with their patients to make sure that they're utilizing an urgent care setting when appropriate instead of an ED also has reimbursement impacts on the hospital, since from a reimbursement standpoint, typically we'll get reimbursed more when a patient accesses the ED versus urgent care. And then multiple influence factors with employers as well, putting more and more pressure on the healthcare setting to reduce their cost of providing benefits to their employees. So different types of value-based contracts. So a lot of these, the contract can really start with a hospital or a health system, the physician or physician practices, or a clinically integrated network or insurance company, and those have different goals based off of those settings. So within that, you can really have three types of value-based contracts: total cost of care, shared saving versus full risk. So those are contract types in which the insurance company or the hospital may have a program in place that should just reduce the total cost of care. So once that cost is reduced, then there's a shared savings based off of the risk. So you can be full risk or partial risk. And then if that cost is reduced while also maintaining or exceeding quality metrics, then there will be shared savings between the insurance company and the hospital system. Quality metrics, so paying for quality exceeding certain thresholds, and then a combination, so triggered cost reductions in conjunction with the quality. So quality metrics, contract rates are calculated based off of defined metrics and benchmark. A great example of that is the Medicare Value-Based Purchasing Program, which we discussed a little bit earlier. It redistributes a portion of inpatient Medicare payment to above average performers. So we talked a few minutes ago about being penalized if you, as a hospital, did not meet those metrics. The penalties and the reduction of the payment that you have gets redistributed to healthcare organizations that are performing above the expected quality. Total cost of care base, providers are incentivized to reduce the entire cost of care across certain parameters. So a good example of that shared savings example is CMS bundled payments, which pays based on performance on selected episodes of care compared to target prices. So this is a program that CMS had done on a voluntary basis. Last year, they just did a mandatory for certain hospitals. If you were in one of those hospitals, maybe a mandatory bundle payment for knee procedures, knee replacements. But a lot of these are elective at this point. You choose to do these bundle payments for specific episodes, then you are tasked primarily as the hospital to work with your physicians and post-acute care in the area to try to reduce the cost and right set the patient for that episode of care, reduce readmissions into the hospital, and then if you are able to accomplish those, then you get payback based off of the target or the national average if you can perform better than the national average. And then a combination of quality metrics and shared savings. A great example of that is the Medicare Shared Savings Program, which pays up to 50% of shared savings after certain performance thresholds are met and is adjusted by a quality score. So we're going to go over just a high-level overview of sort of a new manager financial report training that we do at Ballad Health, just sort of what kind of information that managers are being tasked with and expected to understand in a healthcare setting. So we want to make sure that management's aware of tools and reports that are available and that they have a good understanding of the financial operations of their department and to know where to get that information. So just financial terms, a budget, a formal plan for a defined period of time, which is expressed quantitatively and is used to monitor performance. A capital budget, same thing, usually do an annual process that estimates resources needed for projects, equipment, and facilities. An expense budget accounts for the types of resources used to achieve a statistical budget. Fixed expense is an expense that remains constant over a level of activity or time period and is not affected by changes in volume. And a flex budget is adjusted or flexed based off of actual volume. So this is really useful when departments are experiencing strong variations in volume, increases or decreases, to sort of right size their budget based off of the amount of volume that they've had. Key operating indicators is a set of quantifiable measures used to compare performance in terms of meeting strategic and operational goals. Labor expense per statistic, used to measure staffing costs by dividing labor cost by department volumes for a given period, including team member salary, physician salaries, contract labor, and benefits. And this is a very important metric for managers of units to understand. Operating budget places the responsibility for controlling expenses on to the department manager and include three components: their statistical budget, revenue budget, and expense budget. Productive man hours per statistic is used to measure staffing efficiency by dividing worked hours by departmental volumes for a given period. It includes regular hours, overtime, and at Ballad, education and orientation hours, which at some entities do not include that in their productive man hours per staff. So a little bit different based off of the healthcare organization and how they choose to view things. Productivity measurement. Since labor is the largest expense category for a healthcare provider, approximately 50%, productivity should be measured and evaluated on an ongoing basis. The revenue budget determines gross amounts generated by charging patients for services by multiplying statistical budget by appropriate charge rates. And it's also important to mention, this is something that I think some managers struggle with, but Those gross amounts are not necessarily net or what you get reimbursed. We do have the contractual rates, but since a lot of those are based off of the packaging payments, it is very difficult in a budget or a department operational report to determine the amount of revenue that each specific unit provides. It's more based off of a total for that patient. A static budget is based on a single level of operations that's not adjusted for actual volumes. And the salary expense per statistic is staffing cost by dividing labor cost by departmental volumes. And labor costs include team member salaries, physician salaries, and contract labor. It does not include benefits. A statistical budget is a forecast of volumes for each department and expressed in terms such as visits, patient days, procedures, admissions, or whatever is most appropriate to define the workload of that specific department. A variable expense changes in proportion to the level of volume, and variance reporting monitors actual revenue and expenses against a budget or forecast. So those terms are pretty basic, probably from our standpoint, but if you're have a clinical background, a lot of these are not something that you have heard before or aware of from school. So sometimes it can take a little bit, or we just have to take time to remind people of the different definitions and terminologies that we use. We use a lot of acronyms in healthcare, so sometimes it's really important just to explain those. So a DTAR is a daily transaction audit report, which is used for the managers to review the patient's charge. It typically has a department number, patient number, hospital service code, the charge code, description, quantity, amount, and the service date. So this is an example of what a DTAR would look like. Each department manager should go in each day to look at the charges that were loaded the day before, and then make note of any incorrect information and send that over to make sure that we're charging the correct patients, all of the patients, and not charging anything that's inappropriate. So the revenue and usage report is basically a monthly summary of the DTARs that shows that information. They can review these and again make sure everything's correct, but this should add up to the total of what is on their department operation report for the month. The labor distribution report provides a listing of employees and hours that are charged to departments for each pay period, and it breaks down the time into the categories so that the manager knows how much is productive, overtime, any on-call, paid leave, education, or non-productive hours. And it's distributed each pay period and should be reviewed. So they look at this and make sure that all of the team members were paid appropriately, and then also gives a great indication of the amount of hours, and then also the pay if a lot more overtime versus productive was used or anything like that. The detailed departmental expense report breaks down all of the expenses for the month that were paid through accounts payable, inventory items from supply chain, and then purchase orders that were ordered throughout the month but weren't invoiced through accounts payable. And it shows a lot of the details so that the managers are supposed to review this report each month when the report is available and make sure that all of these expenses were purchased by them or someone in their department. So they're making sure that we're paying vendors for what we should be paying, and they're getting charged to their department appropriately, and should let any of their accountants know if any of this is not correct. And an additional report summarizes expenses by each expense account number and includes everything that's paid and accrued. So that way that the manager has an understanding of the totals in their department report, and they're able to speak to what is in their budget and actuals and why they may be over or under compared to budget. Which leads up to the department financial package or the department operational report. We have 4 key operating indicators: the total expense per stat, the supply expense per stat, labor expense per stat, and productive man hours per stat. So these are 4 areas that Ballot monitors, and managers need to review and make sure that they're in line compared to budget, or explain to their CFO what things are driving them to be over budget, things of that nature. So this is an example of the key operating indicators and what that looks like. So each month when the manager gets the department operation report, it'll be in gray if it's a favorable variance compared to budget. Anything that's unfavorable, the variance explanation and action plan will open. The manager puts a variance explanation as to why they were over compared to budget, and then an action plan and timeline of what actions that they're going to take to mitigate this, and then the time that they're expecting to take those actions. So this is an example of the variance report that we use. So you can see the top section is the statistics, and then the revenue. Then the bottom section is the operating expenses, and then it's got current month, and then the fiscal year to date, actual to budget, and then the flex budget. And so we also put operating expenses that are supplies in green, so that each manager has a clear understanding when they're looking at their supply expense per stat, which actual expense accounts are supplies. And then we have some information with the flex budget, and what that means is basically the volume adjustment. So in the first example with decreased volume, if a department is budgeted for 4,000 cases for the month and only have 2,000, then that flex budget will flex salaries and other items that we would consider variable by the 2,000 instead of the 4,000. So if the cases are 50% of the original budget, then each of those expense line items that are considered variable would be decreased by 50%. And then in the second example, increased volume, if they had 6,000 cases for the month but was budgeted for 4,000, then those expense buckets that are considered variable would increase by 50% for the flex budget, so that it compares an appropriate budget based off of volume to the actual. And those are the metrics that the managers are held accountable for. So a fixed account in the flex budget would still remain the same as the budget. So a great example of that is a maintenance contract. If you have a piece of equipment that you pay a vendor to maintenance, then you typically pay a certain amount each month, regardless of if you need maintenance on that piece of equipment or not. So it really doesn't matter how increased or decreased that your volume is compared to budget. Your maintenance contract is going to be the same regardless of the amount of patients that you have. So in those cases, those fixed accounts would not increase or decrease with the volume on the flex budget, but variable account, again, such as salaries, would increase. So if you had the increased volume or decreased volume with the 50%, then your budget was $400,000 in salaries. The flex budget would have been $200,000. So in that case, if you had actual of $250,000, then that was not flexed enough. You were still over budget, volume adjusted. And with the example of the increased volume, once you increase that volume, your salaries budget would have been $600,000, and then the actual spend was $500,000, then that would have been a positive variance based off of the volume that you had for that month. So this just sort of details out the flex calculation as an example with the budget to flex. The GL details, so this is the report we talked about just a minute ago that goes through all of the journal entries and actual invoices. So if someone has, say, $180 of printing and their budget was $50 and they need to provide a variance explanation for that, then they can go to this report to look at the detail of the information in there to have a clear understanding of where their actual expenses fell. Okay, trend reports. So we do provide some trend reports for the managers that usually looks at prior year actual, current year actual, and current year budget, and do those control charts based on the 4 operating indicators so that at any time that manager has an understanding from a trending perspective if they're going in the right direction or not. So labor management, we do have a labor management department within Ballad that specifically works on the staffing and helps managers make sure that they are flexing to volume and providing the right skill mix for their areas. So we'll go through that just a little bit. We really look at standard work, tight connections, making sure that we're transparent so that the manager has a clear expectation that's communicated on what the staffing ratios are, so that if maybe that manager's not there and 3 more patients come in the door that go into that unit, that those supervisors or individuals that are there know when more staff needs to come in or possibly be called off if there's not a lot of volume. So we're really looking at that proactively. So the department operation report is great. From a labor standpoint, it's very difficult to manage from a department operational report. You end the month, you complete your month-end accounting, and finance completes all of the reports. You're at least mid-month into the next month before the manager gets that department operational report. So it's very difficult for them to make changes to that, or if they're making changes to that, they've already sort of lost another month. So this really looks more on the front end with the unit schedule, daily scheduling, and looking at opportunity during the day or an advanced scheduling based off of predictive modeling on volumes. And so there's specific mechanisms for success, and everyone has standard work expectations from labor. And then coaching, going out and doing Gimbal walks and leadership rounding in the units with the team members, and then having effective handoff communication, and then tracking metrics on a daily basis to make sure that the process improvements that you're putting in place are having an impact. So a great way that gets started, and sort of the baseline for looking at labor, is staffing plans. So those are used to guide volume-driven flexing and determine the staffing mix for volume, which has a framework for managers, leads, and supervisors when and how to make staffing changes for the unit and provide a department schedule each month. So they're made looking at staffing needs, nurse to patient ratios. It's a great example. An ICU unit may have 1 nurse to 2 patients, while a PCU or a med-surg ratio may be a little bit different based off of the acuity of the patient, 4 to 1 or 5 to 1 patient to nurse ratio. Ancillaries consider volume fluctuations between times and days, volume for the weekends or time. So we know in the ED that we'll always have an increased volume in the evening after the physician offices close. So that's something that manager needs to take into consideration when they're staffing. And then also, what's the average daily census or volume? So what is the volume that you're used to experiencing? And then having an understanding of when you're really productive. And day versus night. So patient nursing unit is a good example. In the daytime, when there's a lot of physicians there, you may be admitting patients, discharging patients, and doing a lot of clerical work related to that. At certain hours of the nighttime, there may not be as many patients getting discharged and getting sent home at 2 or 3 o'clock in the morning, so you may not need as many people there based off of those workloads. And then physical layout of the unit. If your supplies are spread out or your patients are spread out, it takes team members more time to serve those patients or to go get the supplies. And so that's something you really need to take into consideration. So start with the budget and the planned budget for the statistics and the hours, or the productive man hour per staff. And then looking at which one of those members are fixed. So a nurse manager is salaried. That's 40 hours a week. Whether they actually work 60 hours a week, that's still 40 hours a week from a labor standpoint. And then looking at the day and night shifts. And so once this gets filled out, you can see it sort of shows where you're productive and where you're not. And then for the amount of patients, how many of each skill mix that you need. So for this unit, there's 6 patients. If you're a nighttime shift lead, then you know if you get a 7th patient that's admitted to the floor, that manager's expectation is that an additional RN would need to come in to fill the needs for that unit. And the daily FTE calculator is another way to look at productive man hours per unit compared to your budget on a daily basis, sort of just tracking your labor every day and looking at the stats to see where your productive man hour per stat is in comparison to your budget. So that way the manager is looking at this every day and not waiting until 15 days after 15 days into the following month before they know where they're at and compared to their budget. But looking at that on a daily basis allows the manager to make adjustments in order to meet their budget. Okay, so next we're going to talk about capital for just a minute. So capital is pretty important for the healthcare industry, and then for hospitals, especially not-for-profits, all of the income made after paying for expenses and annual debt service obligations go towards investment of capital. So how do we define capital at Ballot? A capital is a purchase of anything greater than $1,000 that has a useful life longer than a year and not considered inventory or an expendable item. And then computer purchases. So this is a little different at every organization, but each healthcare organization should have some definition of what's capital versus an expense. Typically, there's 2 phases to the capital process. The first is the project phase. You find out the needs for the capital, how much money that you need, and then get that approved. And then the requisition and implementation phase, where you're completing purchase orders and contracts and the work. So from a project standpoint, each healthcare organization should have some type of allocation of authority that necessitates the level of input. So for Ballot, that's $200,000. Anything below $200,000 requires non-threshold. Anything over $200,000, we do a more robust executive summary and pro forma to evaluate the impact that the project has on our future operations. And this pro forma and executive summary does get evaluated by the executives and gets approval from the president. So funding, each year for capital, you typically have a budget cycle where you project how much funds that you'll have after expenses and annual debt service obligations that will go towards capital, and then do an evaluation of needs and the priority of those needs to define what the threshold capital is. And then each facility or entity has a certain amount of capital that they're provided throughout the year as needs arise, or small dollar needs throughout the year. And then there's the contingency funds. And this is sort of the, let's say the capital standard or best of operations of capital is to have your budget, non-threshold, and then contingency funds for emergency needs. And then there are also other sources of funds for capital, donations, grants. The foundation may raise funds that can be used towards capital projects. But regardless of funding source, you want to have the same process in place from an approval and routing standpoint. And so this is just an example of a capital and operating budget timeline. Typically, we start with the 5-year plan. So we do projections every year for the next 5-year forecast of where we think the market trends are going and how that impacts the financials. Sort of have a guideline of where we think the organization is heading over that 5-year period. Once that's complete, we typically utilize that to start the operating and capital budget process, which takes several months, and do complete operating budgets for each department with the manager or director of that department, and then complete the capital budget for the facilities. Once all that gets done, we sort of look at that and compare, make sure we're still in line with our financial metrics and targets that we evaluated at the beginning of the process with the 5-year forecast, and get that budget and operating capital budget approved by the board, and then operate that for the next year. So that concludes my presentation, and thank you all for taking the time to listen to me. And if you have any questions, you can reach me via email. It's Kellie, Kellie.Simpson@balladhealth.org. Thank you.